Dear colleagues, welcome to a webinar organized by the IPA website editorial board. Thank you for your participation. As you may remember, we launched the webinar program in December 2017 with the aim of building bridges between IPA areas and of facilitating scientific exchange between members. Since last March, the pandemic crisis has led us to focus on the current situation of COVID and its effects on psychic life and analytic practice. Today, we return to the before COVID webinar program, suggest you to focus on the work of the Committee on Clinical Observation and the three-level model. But before introducing you the session and our panelists, let me give you some information on how we will proceed. As usual, the webinar will be divided in two parts. During the first slot, our guests will introduce the main points of their work. Then they will exchange briefly with each other, and during the second slot, we will open the discussion with you, the attendees. You will be able to comment and ask questions throughout the webinar. For doing so, please post your question in the question pane on the right-hand side of your screen. You have to go to the question line. There is a small white arrow that precedes the word question. Click on it to open the question box. Type your question using your keyboard and send it. During the question and answer slot, I will ask out loud the question, and at the same time, you will send the question in your chat box. The panelists will try to answer as many questions as possible. We all know that psychoanalysis is a body of theoretical knowledge rooted in the practice of psychoanalysis and engaging in the method of free-floating attention, which allows psychoanalysts to listen to the unconscious functioning and to libidinal and transferential movements during the analytic treatment. Freud, researcher always respectful of the scientific challenge and responding to the requirement for clinical evidence, gave us in detail his observations of some cases become classic. And in this webinar, trying to update psychoanalytic research, Margaret Ann Fitzpatrick Hanley, Marianne Longenberg-Walleberg, and Louise Perez, respectfully chair, consultant, and member of the International Psychoanalytic Association Committee on Clinical Observation, will introduce us to the challenge of modern psychoanalysis to find ways to observe when and how psychoanalysis brings about a profound change in personality. The three-level model for tracking transformation in psychoanalysis was developed as an observational tool by the Committee on Clinical Observation. It allows to explore the patient's difficulties and to observe the beneficial functional change in them studying sessions. It is being used in psychoanalytic training and research. Before giving the floor to Anne Margaret Fitzpatrick Hanley, a brief presentation. Margaret is a training and supervising psychoanalyst in the Canadian Institute of Psychoanalysis in private practice in Toronto, Canada. She is past director of the Toronto Institute of Psychoanalysis, current chair of the International Psychoanalytic Association Committee on Clinical Observation. She is on the executive editorial board of the Psychoanalytic Quarterly and on the editorial board of the International Journal of Psychoanalysis and Canadian Journal of Psychoanalysis. Margaret Ann, please.
Thank you, Eliana. We're very pleased today to present this stage of work of the IPA Committee on Clinical Observation, formed by Charles Hanley as president in 2009. In the first book published by the committee, Time for Change, Tracking Transformations in Psychoanalysis, edited by Marina Altman, who is the first chair of the committee, the authors describe the development of the three-level model and its questions. To what extent has the patient clinically improved or worsened during the analysis? What are the main dimensions of psychic functioning in which changes have occurred or not? What hypotheses can best explain the changes observed such as changes in the use of the analyst's interpretations, and changes in the patient's capacity for symbolization. What problems observable in the verbatim sessions were not addressed? What alternative hypotheses, referring to the patient's functioning through the years of analysis, could indicate another approach? Today we'll show how the three-level model for tracking transformations in the patient in analysis can be useful for IPA candidates in their training programs. We'll describe innovative courses in IPA institutes, which have been developed to help candidates observe change and absence of change in specific areas of functioning in patients and in the process over long periods of analysis. The three-level model can guide psychoanalysts to observe more systematically what is facilitating the psychoanalytic process and how to do a thoughtful clinical review when a period of impasse occurs. In the second book by the committee, Change Through Time in Psychoanalysis, Transformations and Interventions, the authors bring 10 new extended case studies, theoretical reflections on the 3LM as an observational research method. We propose that the attitude adopted in making more systematic clinical observations complements the analytic attitude of free-floating attention. In order to understand the challenge of psychoanalysis in bringing about profound personality change, which was Wallerstein's phrase, moderators of the 3LM groups focus on analytic listening, together with clearly defined concepts for formulating the presenting pathology and the changes in the patient. Our journey with the 3LM has clarified obstacles too, and challenges to the method, some of which have shed new light on issues we see as having value for psychoanalysts and for candidates. As Riccardo Bernardi put it, today it's not simple to determine to what degree different theoretical approaches are coincidental, contradictory, or complementary, or if they're incommensurable because they refer to different aspects of clinical facts. The central question is no longer a prescriptive one, how an analyst must be, but rather a factual one. What effect does analysis produce in the psychoanalyst's real practice? The 3LM groups consist of 8 to 16 analysts and candidates who meet over 12 hours. The discussion is divided into 3 consecutive approaches to the clinical material. An analyst is asked to bring a brief history, verbatim session material from the first sessions of the analysis, 2 sessions from the mid-phase, and 2 sessions from a recent or final phase of the analysis. Now, the moderator guides the group with the questions in each of these stages and reminds members of the group to refer to the lined text of the clinical verbatim sessions, to read the words of the patient or analyst before each observation they make. A reporter summarizes the group discussion at intervals. The 3LM fosters, then, the presenting analyst's rethinking about the patient analytic process, offering a second look on the process. And it allows participants to see blind spots, successes, mistakes in our work as analysts. It also creates a space to share different theoretical approaches in a manner that feels comfortable and provides a good opportunity for open discussion. In our area, institutes in North America have made various uses of the 3LM. For instance, Judy Kantrowitz and Stevie Smith in the Boston Psychoanalytic organized a clinical weekend meeting, a 3LM meeting, as part of a professional development seminar. And then they started a new professional development course with analysts, mid-career analysts, meeting every month for 2 hours to look through a whole case of analysis. This was a successful model. In the Michigan Psychoanalytic, there was a 3LM organized for the Faculty Association, in which a training analyst presented a 3-year analysis to a large group with a very dynamic discussion. And a course on research includes the 3-level model as an observational research tool. In Toronto, for the past 5 years, we've held a clinical observation weekend in which graduate analysts and candidates have participated, at times followed by 2 seminars for candidates improving formulations in report writing, using questions from level 1 and 2. So let me explain the questions and discussions in level 1 and 2. Each discussion period lasts for about 4 hours. In level 1 discussion, participants are asked to listen to the material read by the analyst. So we get the analyst's voice resonating with the patient in her mind. And then the group describes in plain language, not theoretical language, observations of the patient's difficulties and changes. Shared resonances in the group can open new paths of inquiry into the problem the patient is bringing. Participants are alert to how the clinical material affects them and how to contextualize an observation within a clinical session and over time in the analysis, as well as how a dynamic may be playing out in the group in a parallel process. That's been very interesting for many groups. Observations and intuitions are always grounded in the words of the patient or analyst for validation. Now, out of this level 1 discussion comes a selection of anchor points. These are very particular expressions of the patient, or even enactments, a metaphor, an action, an enactment, an anecdote that captures key conflicts or deficits in psychic structure and functioning that can be traced through the years of the clinical material as it's elaborated and shifts. These anchor points are landmarks. We look forward from them and backwards from them, selected because elements of the difficulties revealed in the anchor points are repeated with variations in later sessions. Good anchor points will offer highly condensed depictions of the patient's core dynamics on entering the analysis. Let me give you an example from the case of Miss C. And we thank the analyst very much because she's presented this case 3 times and we've studied it in the committee. So one anchor point expression from which we could observe change was a bodily metaphor in an early session. Misty said she liked to stay chill, above ordinary needs and feelings. She liked to think of herself as self-sufficient, on top. But in a contradictory way, Miss C described, without any feeling, no anxiety, a very risky lifestyle involving sex and drugs with strangers and near strangers. She was a professional, but her weekend and evening life was spent in this way. 6 years later in the analysis, participants listened to Miss C's associations as she worried about being disconnected, now worried about being chill, telling the analyst with anguish that she sometimes feels emotionally numb, afraid of not feeling things properly, scared to not feel the fear. The specific shift in the patient was that she could feel anxiety and express it, and that what she thought of as an accomplishment, being chill, on top, she now experiences as a problem. In this period, Miss C got married. After these hours of reading and exploring all the sessions, talking in ordinary language about these beginning problems, finding these anchor points, there's a report made, and then next comes level 2. The questions conceptualize the main dimensions of the problems and changes that are discussed phenomenologically at level 1. The areas of psychic functioning used in conceptualizing are the subjective experience of illness, patterns of interpersonal relationships, the main intrapsychic conflicts, the mental capacities and personality functioning of the patient, and a personality disorder if there is one. The level 2 discussions, also referring to specific lines in the verbatim material for every point, can highlight the unevenness of transformations, change in certain areas of functioning, no change or deepening of the conflict in the patient's life, the associations, or the transference. This is important for candidates, both to be modest and to gain confidence, seeing that certain aspects of the patient's psychic functioning are accessible to change in the analytic process, while others are not yet changing. Now, the questions in level 2 focus not on symptoms or signs of well-being, but on the core concepts of psychoanalytic theory which underlie them. Even these conceptually oriented questions are expressed in the most theoretically unsaturated way possible, in ways that sharpen observations of the verbatim session material, so analysts and candidates from different analytic traditions can reframe the ideas in the light of their own theoretical preferences. This makes it possible to discover that different theoretical concepts sometimes refer to the same clinical phenomenon, which eases communication between analysts, identifying with different theoretical traditions. Now, a second group of questions, patterns of interpersonal relationships, has its origin in the classical notion of transference and countertransference, but refers also to external relationships past and present. In the case of Miss C, when we explored her relationship patterns with the analyst and whether they changed, we could observe changes in her capacity for closeness and intimacy with the analyst, a change in that initial wish to be chill. She'd begun with a dangerous, chaotic sexual and relationship life, lacking signal affects, most notably anxiety. In the 6th year, Miss C is married and is pregnant. The analyst is leaving for a holiday and interprets a displaced anger in the here and now transference. Miss C responds, "You are leaving for all this time, and I'm pregnant, and so much is going on, especially the week in January. You won't be here for the holidays. I do feel angry about that. I can feel it in my jaw. It's because you're not going to be here that I'm in this state, this really efficient getting things done state. That's your doing." Her capacity to tolerate dependence on the analyst is present. It's palpable. The distance between the vaunted chill of the first sessions and with split-off anxiety, which only the analyst felt, and the analyst felt it in spades. She struggled with her anxiety in the early sessions. And this expression now, in touch with her needs and her body and new, less dangerous defenses, getting things done, it clarifies change. That's what we mean by the anchor point as a landmark that we track through the sessions. Now, a third group of questions explores, and it's interesting how in a group, the group comes back and keeps resonating to this particular moment, right? What's going on here? And there's more depth here. And that always turns out to be this anchor point, right? That we track and try to understand the depths of. So a third group of questions explores the patient's main intrapsychic conflicts. Changes are viewed through the lenses of the conflicts traditionally highlighted by psychoanalysis. Change can be seen when the patient is capable of more flexible use of defenses, less use of defenses that distort or restrict internal or external experience. And here the model helps us all and helps candidates to differentiate the way in which conflicts are expressed by patients who have well-integrated psychic structure and patients who have a lower level of integration, that is, with borderline organization, characterized by primitive defenses and structural deficits, or a perverse organization. In the case of Miss C, in the first years of her analysis, her conflict between desperately wanting to connect and her fear of dependency were unknown to her. In the later session of the analysis, we observed Miss C capable of tolerating some triangulation and the painful affects that went along. She was angry, for instance, when the analyst clock was turned away from her, turned away from the couch, clearly, she said, for other patients. And a fourth group of questions on mental and personality functioning explore vulnerabilities, fragilities, deficits, developmental arrests in the patient when they first come to analysis. These questions ask participants to explore indications in these sessions of the patient's capacity to perceive or not what occurs in her own mind, and to build based on that an integrated sense of personal identity. Miss C felt disconnected from herself, and she seemed to have no sense of the mind of the other when she came. When she provoked, for example, intense jealousy in her boyfriend without having a clue about what she was doing. There was a famous moment when she told her boyfriend she was going to have another naked lunch with her colleague, had no clue why he'd be jealous. In the second, and the group came back to resonate with that. Now, in the 7th year, when she saw the clock turned away for other patients, rather than provoking jealousy in another person, Miss C accepted her own painful feeling of jealousy. She was no longer chill. Another question on structural functions considers the capacity to have deep bonds with internal and external objects. Toward the end of the 2-day discussions, participants reading and rereading the session verbatim material from Miss C's analysis could see another meaning in the metaphor chill, for a bodily experience, because Miss C had been fighting against an internal bond with a depressed mother, and we got to know that depressed mother better, causing an unprocessed depressive experience, an internal chill. Now, Marianne and Louisa will describe more about the model, more about level 3 approach to the material and its usefulness. But I'll say in conclusion that the 3-level model can show candidates how to observe, and all of us, how to observe the problems the patient brings, to listen for the specific language and affects in those first sessions as they're repeated, elaborated, and gradually change or not. In the 3LM groups, candidates can see experienced analyst presenters expecting blind spots in their own work. They can see there are changes in the patient in some dimensions, less change in others. So the 3-level model group activity can be useful for graduate analysts too. As IPA President Virginia Unger has said, It's through specifically psychoanalytic activities that we remain and develop as psychoanalysts. Thank you.
Thank you, dear Margaret Ann, for this so clear presentation of the level 1 and level 2 and how this can help candidates with their training. Now it's Marianne Ledinger Bolivar. I will present her. Maybe everybody knows Marianne, but I will try to present. Marianne is training and supervising analyst of the German Psychoanalytical Association, DPV, and the International Psychoanalytic Association. Marianne is past director in charge of the Sigmund Freud Institute in Frankfurt, professor for psychoanalysis at the University of Kassel, and she is chair of the Committee for Research and Universities for the DPV. She is chair of the research subcommittees for conceptual research of the International Psychoanalytical Association. And since 2010, she is vice chair for Europe of the IPA Research Board. Marianne, please, it's to you.
Yeah, well, thank you so much for the nice introduction, and Margaret Ann for organizing this webinar. I thought that in my statement, I would like to supplement the presentations of my two colleagues with some brief historical remarks about the context in which the three-level model was developed, because this makes understandable why and in what way we are applying the model in Frankfurt at the moment. Already in 1926, Freud wrote, I quote, "In psychoanalysis, there has existed from the very first an inseparable bond between cure and research. Filling this so-called Freudian Jungteam von Forschen und Heilen, the bond between cure and research, with new and innovative ideas for keeping it alive, inspiring and preserving it from becoming an empty envelope, remains one of the central challenges in contemporary psychoanalysis, even in such difficult times as the corona pandemic. In my view, the three-level model, which we are discussing now, can be understood as such an endeavor. In 2000, under the presidency of David Tuckett, the European Psychoanalytic Federation initiated groups to discuss and optimize training and exchange among psychoanalysts of different traditions and different cultures. After 10 years, a midterm review was carried out at the EPF Congress in Copenhagen in 2011 to decide which group should be continued. The clinical comparison method, the CCM groups, for example, use detailed reports of psychoanalytical sessions to investigate how psychoanalysts work with their patients, what specific treatment techniques they use, what models they have in mind, and how they are influenced by their conscious and unconscious identifications with specific psychoanalytic groups, concepts, and so on. One of the most important results of the CCM groups, in my opinion, was that a new culture of mutual listening to each other was created instead of the unfruitful wars of faith about which psychoanalytic theory was the best, true, and the only one. It was necessary now to critically reflect together on the opportunities, but also the risk of theoretical pluralism in contemporary psychoanalysis. In view of these achievements, I proposed in the just mentioned evaluating panel in Copenhagen that this culture of mutual listening and understandings in times of theoretical, clinical, and scientific pluralism should now be made fruitful for our central concern in psychoanalytic treatment, to focus on the changes of patients in psychoanalysis. As important as analysts, their theories, and treatment techniques are, psychoanalysis is not an end in itself. Ultimately, they always serve the desire to initiate lasting psychological transformation desired by our patients. Only because patients are suffering and wish that they would feel better after psychoanalysis do they seek us out. This also applies in particularly challenging way to training cases. The Project Committee for Clinical Observation had already been appointed by the IPA President Charles Henley in 2009 with the following members, the first committee: Marina Altman from Uruguay, Marvin Hurwitz from the US, Margaret Hanley from Canada, Ricardo Bernardi from Uruguay, our current president Virginia Ungar from Argentine, Siri Gullestad from Norway, myself, and Adela de Duarte from Argentine. She was consultant. In Copenhagen, the project committee met and discussed the complex task just described and started to develop the three-level model of clinical observation, which is presented in great detail, particularly by the paper of Ricardo Bernardi in the volumes just mentioned by Margaret Ann, by Marina in 2014, and by her new book in press. The application of the 3LM to observing patients' transformations in international groups has become very popular among psychoanalysts in all different regions of the IPA. At present count, 1,800 clinical observation groups have been moderated in national meetings and local societies in Latin America, North America, and Europe, and in the pre-Congress of the IPA, FIPAL, the EPF, and APSA. The 3LM offers a possibility for psychoanalysts with different theoretical orientations to refer to common criteria. Against this background, our group in Frankfurt applied the three-level model in two different institutional contexts. First, we used it as a supplement to the sophisticated quantitative research in a large outcome study, the luck depression study, in which 252 cognitive behavioral and psychoanalytical long-term treatment with chronically depressed patients have been investigated. With the help of the 3LM, we studied the transformations in several psychoanalyses in great detail and systematically in the weekly clinical conferences. The 3LM enabled us to conduct a series of single case studies to improve the quality of the narrative summaries of these treatments, focusing on different aspects of the transformations of the patients. Some of these narrative case studies will be soon published in German. Was nur erzählt und nicht gemessen werden kann, what only can be told and not measured, edited by Ulrich Barke, Alexa Nägerle, and myself. The second application, based on these inspiring clinical and research experience in the frame of the luck study, the idea was born to offer the 3LM to a group of candidates. The aim was to discover together if and how the 3LM is suitable to discuss training cases systematically and creatively in a mixed group of candidates and training analysts. The aim was to examine in clinical psychoanalytical terms whether and how transformation takes place, in the hope that the insight gained will prove helpful from the candidates involved. In 3 semesters, weekly seminars were held in which about 6 candidates and 4 training analysts took part. After an introduction in the 3LM model in one evening, a candidate presented one of her ongoing training cases in 4 following seminar sessions. We discussed 7 psychoanalyses so far and continue next winter semester. In the first seminar session, the initial interviews, the health insurance report, and the psychoanalytic session from the initial phase were presented in detail, leading to the definition of the anchor points. Margaret Ann has just described what that means. In the second seminar session, after a short summary of the analytic process since the presented session, a psychoanalytic session from the later phase, and in the third evening, a recent psychoanalytical session was discussed in detail. The 4th seminar session served to discuss the transformation that had taken place with reference to the 3rd level of the 3LM. Now to the impressions of the candidates as well as the members. All members of the 3LM groups found the 3LM experience intensive and enriching. The intensive study of detailed clinical material from the same psychoanalysis over 4 evenings proved to be worthwhile and expanded insights into the conscious and unconscious dimensions of the analytical process. Also, the detailed documentation of the often intensive and sometimes controversial group discussion was very time-consuming. It resulted in a valuable report of the successive understanding of the clinical material. It proved to be helpful for the candidates as well as for the group members not to lose sight of the forest for the trees. It took some time for the group to find a productive way to discuss level 3 and the attempt to illustrate the transformation that had taken place from the different theoretical perspectives. These discussions became increasingly fruitful. To mention just one example, discussing level 3 of one of the training cases, the training analyst tried to apply a developmental, psychological, gender-specific approach, a trauma-specific consideration, and a Kleinian object relation theory and the drive theory explanation to the same clinical material, very systematic. It remains for us an open question whether this can offer the candidates a helpful orientation in times of theoretical pluralism, or whether it represents an excessive demand. It's very demanding. One candidate described how she struggled in her treatment to avoid theoretical top-down views, just putting always the same theories onto a single patient in a rigid top-down manner. As Margaret Wren has illustrated, the differentiation of the 3 levels of the 3LM is intended as an aid in dealing with this danger. First, an attempt is made to discuss transformation on a phenomenological level. Level 2 is about individual dimensions of observations which are to be described with clinical material very concretely. Margaret Ann has given an example. And only in step 3 is an attempt made to play with the theories in the sense of dealing with the richness of theories in contemporary psychoanalysis. Depending on the focus of the theoretical kaleidoscope, other structures become visible in the complexity of the clinical material. One specific problem area should be mentioned briefly. One training analyst had feared that our seminar could lead to conflicts with the supervisors of the training cases. This concern was not justified. The 3LM offer is intended as a supplement, not as an alternative to regular supervision and technical seminars within the psychoanalytic training. It is well known that the continuity and the holding function of a responsible supervisor for a training case is needed to provide a safe, holding, reflecting home base in the sense of case-based learning. However, the downsides of such personalized learning models have been subject to critical discussion within the IPA for many years. The master-student relationship carries certain dangers, such as the submission to authority, hindering one's own innovative and creative development, etc. It sometimes reminds one of religious as opposed to scientific institutions. The experience in the small 3LM group are particularly interesting against this background, as they enable the recurring experience that perceptions, perspectives, understanding in the sense of sense structure of unconscious fantasy and so on could be quite different among the 4 training analysts as well as the candidates, sometimes complementing or even contradicting each other. However, it is always important to stress that the 3LM discussions are about expanding psychoanalytic understanding in an open space of creative clinical thinking. It aims not to evaluations and assessments. This is particularly important for the treatment in difficult treatments. The responsibility for the treatment lies, of course, within the treating analyst and his or her supervisor. We also discussed whether the great amount of time and intergenerational commitment is really worth it. Because today's candidates are very busy, it is important for some candidates that they can use the 3LM seminar as a direct or indirect preparation of their case presentation to finish their analytic training. So let me conclude with a brief account of what a candidate herself has written about her concrete experience within the 3LM. Louise Letzer, a candidate, writes, while even the best case seminar in which one presents one's own case once during the semester remains an important experience, and the considerations coming from the group and from the lecturers refer mainly to the respective presented session, the 3LM model seminar with 4 sessions per case offers the opportunity for an in-depth exchange in which the entire treatment from the beginning to the current phase of the analysis or even beyond that comes into view. This is something very special and valuable. Not only was I able to experience what the training analysts were thinking clinically and conceptually about one specific session, I also had the opportunity to observe the different trains of thoughts of the experienced training analysts throughout the complete analysis of treatment. I was able to feel how training analysts, drawing on their experience and including past and current cases, deal with the wealth of transference, countertransference observation, how they would react professionally in difficult clinical situations, how they would digest them and embed them conceptually. I could observe that some working hypotheses have to be discarded, that it is always a challenge to acknowledge the not knowing, and that we analysts can nevertheless trust the analytical method, the talking cure, again and again. I skip a paragraph because of time and just finish. She says, from the perspective of a candidate, I can say that through the 3LM seminar, the lived and even suffered psychoanalysis as a profession in its most diverse facets and its great moments became tangible and tangible for me. Just as good surgeons can only pass their experience to the next generation in their joint practical work at the operating table, the 3LM seminar enabled me to participate in such a practical transfer of psychoanalytical knowledge. End of quote. Thank you so much.
Thank you, dear Marianne, for this rich presentation, tracing the history and the goals of the committee and the model regarding the development and the future of psychoanalysis. And now, Luisa, please, it's up to you. So I had to present, donc Luisa is a psychiatrist, associate member of the Uruguayan Psychoanalytic Association, former assistant professor of medical psychology, School of Medicine, Universidad de la República Uruguay, past vice president of the Latin American Organization of Candidates, OCAL-FEPAL, past chair of the study group of adolescents, and current co-chair of the teaching faculty of the University Institute of Psychoanalysis at the Uruguayan Psychoanalytical Association, member of the Uruguayan Psychoanalytical Association Research Group. And Luisa, it's up to you now.
Okay, thank you, Ileana. I'm going to refer to the third level of the 3LM, which deals with the explanatory theories of the patient's transformations. It constitutes the second moment in which the observation of these transformations change its aims. In level 1, candidates step into the observation of the selected fact through the degree in which the clinical material and the group discussion resonate with each participant. From the articulation of these two elements, the anchor points arise, which will guide us through the other two levels. In level 2, with these anchor points in mind, they enter step by step into the dimension of the patient's subjectivity, as was described previously. The observation's objective at this level is to see in what way the anchor points were modified or not throughout the analytical process. Following the thread of the metaphor transformations is a useful guide for observing these aspects. Participants arrive at level 3 keeping in mind the anchor points, their modification throughout the process, and the detailed description of the dimensions in which these transformations occurred. At this level, there is a shift in the observation's goal. The aim is to think about the best possible explanation for the changes observed in the dimensions analyzed in level 2. The analyst's implicit theories of change, evidenced through his or her interventions, become explicit through the group discussion. The group considers both implicit and public or official theories in the analyst's mind. 4 questions will guide our observation at this level. The first one leads to a transversal and longitudinal observation of the analyst's intervention focuses. Transversal, regarding each intervention, its context, and its relationship to the selected anchor points. Longitudinal, concerning the changes over time and whether these changes were related to those observed at the anchor points. These aspects introduce the second question. What were the possible mechanisms of these changes? What were the therapeutic factors that influenced them? One mechanism, among others, could be the analyst offering himself as a new object to the patient, developing a different emotional experience from the patient's current and past emotional ones. To reduce the biases that could mislead us, it is necessary to refine the observation. For this purpose, the third question leads to observing what material was not included or was not sufficiently explored in the analyst's sessions. In this way, biases of omission decrease. That means reducing the risk of assuming a hypothesis when we lack information. To diminish other types of biases not described here, this question proposed thinking of possible alternatives to the analyst's intervention that could have been useful for the patient as well. These 3 questions provide the participants with the necessary elements to answer the fourth one. What other hypotheses could be considered from different theoretical perspectives? What is their contribution to the understanding of the clinical material? That is to say, with the elements that we have, can we explain the changes in another way? If so, in what way? The observed transformations can be understood from different explanatory theoretical models. It is not a question of selecting one theory or another, but examining which one has more significant clinical support. Alternative hypotheses require new material and broader contextualization from the analyst. The confrontation of hypotheses is necessary to determine their strengths and limitations when explaining the mechanisms of change. That is to say, what degree of evidence we can find in the clinical material to support each one of them. Let me show you how this level works with an example. Jay, a 30-year-old married man, came to analysis feeling overwhelmed and with difficulties in organizing his life. He presented as a very rational person with a meticulous, monotonous discourse in contrast with its content. The first focus of the analyst was on Jay's masochistic functioning. The group understood some of the analyst's interventions as provocative and aiming to ease the patient's rigid defenses. The interpretative focus varied along with the analysis. The analyst sought to ensure that Jay did not deny reality, his wife's affair, and could get in touch with his emotions. I quote, "Is it comfortable for you not to work on this issue with me?" 2 possible mechanisms of change were discussed. The analyst offering himself as a new object, representing for Jay a new emotional experience in containment and support, and the introjection of the analytic function that allowed Jay to move from the obsessive rumination of the beginning phase to the reflexive function in the ending phase of analysis. The group highlighted the patient's slip of the tongue, which the analyst noticed but did not explore. I quote, "Thinking that this is what I want as a woman." Following this thread would have opened a path to enable contact with a passive and conscious desire, me as a woman, and to approach homosexual ambivalence. The analyst refer to Freudian theory about Oedipal conflict, castration, anxiety, and desire. At the beginning of the analysis, J's ego appeared suffocated, crushed by superego ideas and the external reality in which he lived. The analytic work sought to make defensive functions and the permeability between psychic instances more flexible. Members of the group proposed a Kleinian perspective to understand the patient conflicts. They suggested a transformation in a schizoparanoid functioning with the integration of split-off aspects of idealization devaluation giving place to depressive affects. From a Winnicottian perspective, J acquired the capacity to be alone in the absence of the analyst. From a Bayonian one, he was able to incorporate the reverie function of the analyst, which would allow him to consult in the future if needed. I will now turn into Latin American experience using the model in the field of psychoanalytic training. The different institutional contexts have adapted the model to the realities and demands of their psychoanalytic communities. Various modalities were used setting up the 3LM groups, groups only for candidates, mixed groups of candidates and members, and other ones in which qualified members were included as consultants. The time assigned for group discussion was modified according to the institutional schedules to 8 hours. On some occasions, they had been carried out in 2 or 3 meetings of 4 hours with an interval of several months. There were also variations in the use of the 3 levels. Some groups only work on the transformations from the phenomenological point of view of level 1. Others discuss them from the dimensional perspective of level 2. Most of them completed the discussion of the possible theoretical explanation about how the changes occurred posed by level 3. In Peruvian Psychoanalytic Society, a working party only for candidates was held in 2019, despite group members were held since 2012. The scientific secretary specified that 3LM would allow the candidates to carry out the graduating paper to become a member of the society. In Argentina, Liliana Fudin and Adela Duarte introduced the 3LM in the training program of the Argentinian Society of Psychoanalysis for the first time in 2013 as a pilot study to test the model's effectiveness in further developing candidates' observation skills in clinical practice. Since then, it is part of the psychoanalytic training. In Brazil, Bruno Salesio has been running groups since 2013 in which candidates are encouraged to participate together with members. In Uruguay, although the model is not yet part of the analytic training for procedural reasons, an annual working party is held under the auspices of the teaching committee and the scientific committee of our institution. The presenters are candidates in different stages of training. Marina Altman and Beatriz de Leon ran a group in response to our institute's concerns about the difficulties of a large number of graduating candidates to write the final paper to become an associate member. They work on 3 hours monthly based sessions for 2 years. Many of the participants were able to present their final paper. Despite the variations of the formal aspect of using the model, the common ground is that the guided discussion promotes an integrative listening through close observation of clinical material from different perspectives. Formulating new questions encourages openness of knowledge that can be transferred later to the final paper to become an associate member and to congresses, conferences, and publications. By studying the process through routine sessions for long periods of time, the 3LM puts candidates in touch with the real practice, not an idealized one. Listening to oneself as an analyst in the group context produces a different effect than supervision, which performs both teaching and institutional evaluation functions. When the candidate's presentation is during the ongoing training, the model allows visualizing the patient's transformations by focusing on aspects of the clinical material that had not previously been taken into account or not even formulated as dimensions to be analyzed. The systematic exploration of the patient subjectivity awakens multiple resonances that produce effects in the candidate's analytic work, allowing for a deeper look into the patient's conflicts and opening questions about the analytical process. In an ongoing analytical process, the group discussion produces an effect in its continuity to the extent that the encounter with the patient is no longer the same, because the analyst carries new visions and questions that inhabit him in that encounter. Toward the end of the training, at the time of writing the graduation paper, the model acquires a unique value. Selecting which aspects of the analytic process to work on involves leaving out many that may have been important. The model proposal focuses on those significant moments to the analyst and the patients, either because of the emotional experience, moments of thoughtful insight, or impasse. Through its three levels, the candidate is proposed a fine observation tool of his work and a clinically well-founded conceptualization of it. The fruitfulness of these experiences for candidates lies in creating a space where they can reflect on the clinical material presented as participants and attentive observers, and intervene without the pressures of institutional evaluation. Thinking about patients' transformation or their absence encourages them to evaluate themselves about how they work with the patients. The preference given by the model to the clinical phenomena inspires an attitude of clinical research that fosters the basis for candidates' future personal development as a complementary starting point to the demands of psychoanalytic training. Thank you.
Thank you, Luisa. Thank you very much. Thank you for giving us the third chapter, the third part of these three IPA areas panorama, and the way and how the three areas use the 3LM model. We have some time left before to proceed to the question and answer session. I would like to ask you if you have some questions that you would like to discuss between you. Margaret Ann, maybe you can start.
I was just going to continue with the look at the third level, which Luisa has clarified, and to ask, for instance, to ask Marianne. We worked a lot on the case of C, and the case of Miss C, and Marianne worked further on the theories behind the depressive aspect of the patient that were shown through the interpretive strategies that the candidate, well, a graduate analyst had used in relation to this bodily metaphor of chill. I don't know whether, Marianne, you could say a little bit more about the use of a implicit theory that gets at what the bodily metaphor is like when it's used as an anchor point.
Well, I don't know if I can go into the details. I think because it's a webinar, I just want to express that just the fact that the model has been used and be fruitful to so many groups in the different areas. I personally am very proud of that. That means that it captures something of a form of communication and to make clinical observation a little bit more systematic. Yeah. I think at the same time we have to be modest. There is a lot to do. I think it is, for me, it is a tool to get into contact and to improve our clinical observation. As you know, as a researcher, I'm skeptical if that is really already clinical research. I mean, it is clinical research in the sense psychoanalysis understands it. That's why I quoted this Jung-team research by Freud, the combination between cure and research. But I think we are in a research community. I mean, you are coming from the medical field, you, Louisa, and you know there is a tension, of course, for the understanding of science, which is accepted, for instance, in the clinical world. And you mentioned the depression study. It was a bitter pill that our 3-level improved case studies, they are accepted by literary persons, by artists, by patients, even some politicians, they like to read case histories. But in the world of evidence-based medicine, they are not accepted as evidence-based knowledge. And this is a tension. I think we just have to go on discussing this. And in your new book, we are discussing that. In the new book of Marina, we are discussing that. I think we are on a pathway. And for me, the 3-level model is an important step. And as we try to show, I think it's a very good tool in training to just sensitize the candidates of the state of art we are in as a psychoanalytic discipline, as a clinical discipline, and hopefully also as a science of the unconscious. I don't know if I went into the direction you wanted to, but you can add what you wanted to ask.
Margaret?
Well, I think maybe Louisa would like to say something about that because she's been working on evidence and thinking about the candidates. So Louisa, why don't you say something?
Okay. I think that the level 3 can improve the observation of the evidence or not evidence in the theoretical background of the analyst work. There are some elements that could help to find that evidence. It's about the interventions of the analyst and the context and the response of the patient. We can observe if they are matching or articulating, or even if there are two parallel discourses. So I think that what I agree with Marianne that it's not easy to find evidence to demonstrate as in medicine, evidence-based medicine. But I think we can observe that in psychoanalysis, we developed this with Riccardo Bernardi, a higher evidence, we can find a higher evidence when the contextualization and the response of the patients are attuned, you know, and the confrontation of different theories can question the strengths and limitation of the theories that are we are working with. I don't know if I answered your question, Margaret.
Well, I think that is clinical evidence, you know, and that is a big tradition in hermeneutics and in psychoanalysis.
Yes.
But I think we have to be aware that it is a different kind of evidence than, for instance, in the world of evidence-based medicine and psychiatry.
Yes.
Yeah. Let me get back just to the step forward. I think that coming from the study of English literature for 20 years, right? I was always surprised to hear people say that there was the evidence that was presented in literary case studies was not paid attention to, or was not very systematic. But in fact, you can get 200 years of approaches to a Shakespeare play or a Jane Austen novel, and you can see the approach to the novel building up with tremendous certainty over the decades, because the text just resonates from the beginning, middle, and end of the narrative of a novel with a certain phenomenon that are going on. And what surprised me, and I think all the groups that I've moderated, and I think this is true for all the moderators in the 3LM, is that the participants of the group are very surprised at how clearly they see this patient and analyst and certain things that are going on in the analysis change from the beginning to the end. I mean, there's certain things we're uncertain about at the end, but it's been a remarkable journey for the last 12 years to see group after group work from different angles and say, oh, this is happening. This was such a problem at the beginning, and the patient is on this dimension so changed at the end. So it's a step forward, I think. It certainly helps candidates. And when I'm supervising, I think all of us who work with the 3-level model and are supervisors, we see the candidates looking at the formulations in much more precise lines. I think those of you who are researchers have in your minds so many precise, differentiated lines of dimensions of psychic functioning. But for us who come from other traditions, these differentiated lines of psychic functioning, which a candidate can see clearly even over 6 months, has changed. Change in a certain primitive defense, change in the sense of self, right? It very much helps, I think, look at with confidence what can be seen in an analysis. So that's from my point of view, and from the point of view of moderating many, many groups over these 10, 12 years. I don't know if that's your experience, Louisa and Marianne. Well, I think, Louisa, you've been in many groups, and because Latin America has probably held the most in FEPAL and in all your societies over these years.
Yes, we have the same experience. Yes, and candidates are not only candidates, analysts and expert or with analysts with a big expertise get surprised by the analyzing the different dimension and the changes, you know, that the patient has, as you said, in 6 months, in 2 years, in long periods. And the observation, such a detailed observation, makes a change in the analyst point of view of what psychoanalysis can be. And because it's centered on the transformation of the patients, and they can observe this with in a very refined way.
Yeah, it's been fun for some of the graduate analysts. Like, they've graduated for 4 or 5 years, and they have a case that they began in supervision, so they have very detailed verbatim session notes from the beginning of their analysis. And then here they are, 5 years graduated. The analysis is at a later stage of the analysis, and they present the first sessions, maybe a mid session, and then a very recent session. And they can rethink the case and gain confidence in what's happened to the development of the case in those 5 years. So there have been a group of presenters, including the presenter of the Miss C case, who were in that early career stage, gaining confidence. And sometimes when it's an analysis that's not completed, the presenter goes back with a refreshed sense of what's going on in the case, both that they are conscious of, and that some of them have implicit things that have been going on that they haven't really, that the whole group can make them much more aware of. And then they bring that to the patient.
Thank you very much. Thank you very much. I feel that you have a lot to say, the three of you. I propose, because it is time to pass to the question and answer session, to continue this discussion with the questions. So I will start with the first question. It is addressed to Margaret Ann. You presented a very clear and panoramic explanation about the 3LM proposals. Is there 3LM experience with psychosomatic clinical material, that is to say, body metaphors?
Yes, we've done a lot of work we have done quite a lot of work with bodily metaphors and some with psychosomatic material. There is a case that Marina Altman has developed, which tracks a bodily metaphor from beginning to end of an analysis that's going an extended case study in the recent book. We also have a paper we presented where a patient came with fibromyalgic problems. It was a year after his mother's death, and he was curled up with pain in all of his hands and limbs. And we watched through the analytic process how that problem, the physiological problem, ended, and then we saw the much deeper problems that were ongoing and that were implicit in some of the originals, the first sessions.
Somebody else want to answer? Marianne?
Well, I think, well, yes? the concept of metaphors and of embodied metaphors, that has been a topic. We had a whole panel, I think it was it in London, Margaret Ann? We had a, yes, I think metaphors, as we know from psychoanalytical history, are on a very good level of abstraction in order to capture primary process material and to bring them in a first attempt of language, which is not very abstract. I think this is one reason why it is an important step of communicating and to make implicit theories explicit also for the analyst, but of course, particularly for the psychosomatic patients who are not able to mentalize or to symbolize. So I think the metaphors is a very interesting topic, and it's often embodied. It's very close to the bodily experience.
Luisa?
No, I have nothing to add.
Okay, I will go on with the next question. Dear Marianne, thanks. Okay, go on. Yes, please. Please, Margaret Ann. Please, go on.
I was just going to, yeah, okay. I was going to give one example where a patient came and with this, he said that everything was on fire. This patient that had this psychosomatic pains, severe pains in his body. And it was that situation that unfolded was a situation that was close to Janine Chesquet-Smirgel's work, where he'd been left alone at 3 years old with his mother, and that there had been a situation where the father had left, and the mother was very disorganized, very warm. And then suddenly she got married, and so on. So there was this whole situation of being on fire a year after the mother had died, showed in the long run in the analysis the traumatic experiences of a somewhat seductive mother and the little boy being too close, being too included, and then too excluded in the primal scene. So that was an instance of the development of that metaphor. Everything is on fire. To the, first of all, in the present physical, and then in the psychological situations which emerged from the early stages with the mother.
So you're saying that maybe this 3 model, I'm just thinking about it. It's a kind of parexcitation or of parexcitation. I don't know how to say it in English. It's the excitation framing, how to contain the excitation. regard not only for psychosomatic patients, but for every situation that you presented. It's a kind of frame that it contains excitation that it cannot be verbalized or worked through during the analysis. It's an additional frame, maybe.
That's an interesting way to put it, because certainly things go on in the group process which resonate with what's gone on in the analysis. Yes.
Okay. I will go on with the next question. It's to address to Marianne. Dear Marianne, thank you for your presentation. How do you think the 3LM as a tool of transforming the psychoanalytic training, as I will read it again. Dear Marianne, thanks for your presentation. How do you think the 3LM tool of transforming the psychoanalytic training regarding candidates? How do you think?
Well,
what do you think?
It was so. Thank you. Are you through? Is that the question?
Yes,
okay.
Yes.
Well, I think we have heard from Louisa and from all of us that the 3LM can be very fruitful in psychoanalytic trainings. I mentioned this one aspect, which is historically, I think, interesting. We had a whole Sandler conference on education. I have seen that you have a webinar on education. And the question, how to educate the future generation of psychoanalysts, is as old as psychoanalysis. And I think we have not found the solution yet. But for me, the 3-level model, because I say it a bit provocatively, is very democratic. If you are in the group, you know, you are on the same eye level, the training analysts and the candidates with the clinical material, trying to struggle for understanding. And I think that is a very important message, you know, which is kind of another message that we have, of course, to go to the masters in training, you know, to learn from the masters, which is always a problem, that the masters are here and the candidate is here, the little one. And then the danger is, to say provocatively, to identify with the aggressor and to submit somehow. And that's why, that's one reason why many candidates, they really suffer from psychoanalytic training, because, you know, they are mature persons, they have children at home, they are professionals, and in training they feel so small again. And I think in the 3-level model, at least in Frankfurt, we have a very different atmosphere, as Louise Letzer told it. It is a level of learning from each other, approaching the material, trying to understanding, and even on the 3rd level, you know, that to try to look from different theoretical perspectives on the material, not pretending that the oldest analyst has the solution and knows best. It is kind of a more democratic culture of learning, which I think is very good for the psychoanalytic training, at least in Frankfurt. Yeah.
So it is not only mutual listening, but it's also democratic listening.
For me, it is. It is a very democratic form of learning together, which is, I think it's one reason why it makes so much fun to be in these groups, you know. It's not just to submit again or to feel like a teacher or to feel like a little student. It is something on the same eye level, which is just, it's wonderful for me, yeah.
Yeah, in the 3LM groups in Toronto over the last 5 years, the candidates have been there, and they've made some very good contributions to understanding the case as it's gone on. And 2 of the candidates who'd not yet taken a training case said to me after the 2-day meeting, they said, we can take a training case. We can think about the patient in these ways and write a report. So they were inspired both by the insights that they'd been able to make and the kind of thinking about the case that they'd need to do in a report.
Okay. I think that, yes, I think that it's very useful for candidates because the groups, the candidates feel free in the group to address the case and to say what they think about. And it's this freedom, it's not the same in supervision. So the way the groups fosters the capacity of listening and understanding the patient with others. And the resonances are very important because they can say what they think and they can learn. So it's an experience of growth for the candidates. And I will point the freedom to think with others. And what Marianne was saying, no, it's very democratic. Everyone can say what they think, but also I think what is important is that they have to go back to the session and to the lines that there are backing their thinking. No, this is I think this is very, very important because it's not just I think that. No, I think that because of it's there in the material, the clinical material, and this is what I think the richness of the model.
Marianne?
Well, I was a bit emotional and I don't want to idealize it. I think we need probably both models. That's what I tried to say. We also need the supervision as a continuous dyadic way of learning. And I think it is a fact that, of course, it is a transgenerational learning. We learn from the young ones, but I think, of course, the young candidates, they have to learn from the old experienced analyst. And that is always a narcissistic vulnerability. But I think the three-level model could be an alternative additional experience, which, as Louise said, which is good for the candidates because they feel taken very seriously. They are taken seriously in good supervision tools, but I think in the dyadic there is more that the hierarchical structure of the experience and knowledge between the young and the old analysts. So I think we probably need both.
I would like to ask a question. Before reading you the next question from the participants. When you are talking about supervision, you are talking about individual supervision or for group supervision too?
Well, I think in the training for becoming a psychoanalyst, you have to, at least in Germany, there are individual supervisions. Of course,
because the French model.
Yeah. In France, do you have always group supervision?
Yes, we have one individual and one group. That is why I wanted to precise this element. So I will read you the next question. Thank you for this webinar. As a French candidate, I am partial to the French model in which the supervision is one of the pillars of training. It's an analytical experience more than a theoretical one. It opens third function, like the listening of listening and the analyst of the analyst, more than a teaching or an institutional function, although, of course, these are present. How do French candidates or analysts react to the 3LM in your experience? Do you have any candidates in your group who was French candidates? The question. Do you want me to read it again?
No, I'll say something.
Okay.
I think then what I once participated in an EPF end of training evaluation meeting in Vienna, and Marie-France Dispo, a French analyst,
Yes.
French-Belgian analyst, was presenting
Belgian.
her work with, I think, 3 candidates in a group. So I got an idea of how that works. And in fact, the 2 candidates listening to the case presentation of the other candidate will in fact have somewhat of the experience of a 3-level model, because they'll be listening over time to case presentations of each other. The thing that wouldn't be this exactly so it would have that advantage that the 3LM has, that we're all listening together as a group to case presentation. The thing that also is unique about the 3-level model is the longitudinal facet, that it's the first sessions of the analysis with all the intensity that's being brought. And the initiating psychoanalysis working party has done a lot of work on those, and what's the immense condensations of those first sessions, and then mid sessions and late. So that's one other facet that would be in the 3LM. But that mutual listening happens, as Marie-France explained it to us, in the French model.
Marianne?
Well, thank you for this question. I think it shows us that we have very different cultures. So I'm very curious. We have the Joseph Sandler Research Conference in 2 weeks in Lausanne, where we try to bridge the Anglo-Saxon German culture also of clinical thinking, but also of research with the French one. And I think that will be a very interesting point, that you have a different training model, which of course also influences what we call clinical research or case presentations. But I think we could really learn from each other. So I would like to invite you all, because the Sandler Conference will be online this time.
Okay.
Half in person, half online. It is on the IPA website. So it would be wonderful to have people from all over the world, and of course, particularly from the French tradition too. And it's on depression. Yeah.
Thank you very much. I will go on with another question. Do you have any study on validity and reliability of the 3LM? Can you, anyone? No, this is another one. Excuse me. That's now.
We do have one. Well, there are 2 actually interesting. Andrea Pereira from Buenos Aires planned to have one clinical material, which was the analyst was I think I can say that because it's been all published. But anyway, the analyst was from the American Psychoanalytic Association Research Consortium, and he had a case that had been tested and had been tape recorded and transcribed. It had been tested before, during, and after the analysis. So we set up a group in Oslo. Siri Gulestad worked on it. We set up a group in Montevideo, which Louisa was part of, and we set up a group, a 3LM group in New York, where I moderated, and a group of New York analysts came in from other places in the US. And so those 3 separate meetings of the 3LM were done on the same case material that had been tested. And then Andrea Pereira, through an IPA research grant, worked on the research that was done and the 3 3LM groups, which she had tape recorded. So that will be presented at the next IPA Congress in Vancouver. That was a way we were trying to test whether the observations made in the 3LM group tallied with the systematic research. We had done the same thing with one other case. And in fact, the tallying was very close, remarkably close. There was a Rorschach that was done before, during, and after, in which almost the same language was used as the 3LM group had used. And there had been 2 separate groups then. We didn't know each other's reports, how they would be, one in Latin America and one in New York. So that's as much as we've done. Marianne may have done more.
Well, I think we are just on the way. I think the question is probably from an empirical researcher. And that is one problem. I mean, you had this tape recorded session, and you know, reliability and validity in the sense of empirical research, it always needs tape recorded session. And that is a very different model than working in the 3LM groups. But I think we are on the way. And if we would have tape recorded sessions, of course, we could make reliability and validity studies. But that is, I think, still a lot of to do. But that's how it is. We shouldn't pretend that we are already at the end of a process. We're just in the middle. Yeah.
Okay, Luisa, you want to add something?
I agree with Marianne. We have advanced a few steps. We are in our path. I think we are going to achieve something about reliability in the future and validity in the future for the model.
So there is, thank you. There is another technical question and then another question more. Is the supervisor of the specific analysis present at the discussion of the specific session when it is discussed?
Not
That is
necessarily.
Yeah. Mm-hmm.
It is clear, or do you want to read it again? Is
No,
the real supervisor of the case is present in the 3LM discussion?
In our group, it is not. In Frankfurt, it is not. It's separate. The 3LM group is separate from the individual supervision. And as I have told you, there was one colleague was very concerned that there could be some conflicts between the supervision and the 3LM group, but it didn't turn out to be a big problem, at least until now. Yeah. I don't know how it is in your countries, if you have 3LM groups where the supervisor is present in the group.
No, it's not.
No. Okay.
I'm thinking about, but I think they don't. In the experience that we had with different groups, I think they were not present. They are not formally included. If is that what they are questioning.
So the candidates, they have two frames, two places to talk about the same analysis. Because we can imagine that somebody can have the supervision and come to the 3LM to talk for another case. Not the same. In a way of not interfering groups dynamics and transferential movements towards the supervisor. If we,
yeah, that were exactly the concerns, you know, that you would get a mixed with, and well, until now it just didn't seem to be a big problem. But I mean, the candidates, they took, of course, their experience back to the supervisor, to the personal supervision. And you know, in the German model, I mean, I admire these young people. It's such a time-consuming training. And I mean, this is the life phase where many of them have families, have little children. So it is a very tough lifetime. And so the 3LM groups, some of them really could take it as a possibility to be enriched by understanding the clinical material also from the 3LM group, which helped them to write up their case for the final exam. And of course, this manuscript, they are also discussing it with their supervisors and with other analysts. So it until now, but who knows what will happen in the future, but until now, it was a fruitful exchange. It was not a war between the supervisor and the 3LM groups, just a mutual enrichment of both approaches.
Thank you. We arrived at the end of this session. There are a lot of questions. There are, I feel, a lot of aspects to discuss and exchange on them, but we don't have any more time. I would like to thank you very much, dear Margaret and dear Marianne and dear Luisa, for this so interesting and so lively discussion and presentation. I think that we should say that in the future we are going to discuss again, maybe because there are a lot of questions left, and it is always on process, this model, if I understood well. So thank you very much.
Yes.
Thank you.
Yes.
Thank you for the good moderation. Yeah.
Thank you, Eliana. Thank you,
Thank you,
Eliana, very
Eliana.
much.
Thank you to you. Thank you. So the next, the future webinar, I think we have to, voila. We have to visit the IPA website for the latest information about our webinar program. Till then, keep safe. Bye-bye.
Bye-bye.
Thank you.
Bye-bye. Thank you.